was actually going to ask her if she has that.
That's free advertising.
That's very good, thank you.
Okay. Well, hello everyone. I think we should begin. I'm hoping you can hear us in Saskatoon. Can you hear us? Lisa?
Yes, we can hear you.
Okay, great. Well, it's my great pleasure to be able to introduce Jerry Hurley, who is a professor and the chair of the Department of Economics at McMaster University, to speak on the issue of the response of Ontario primary care physicians to pay for performance incentives. I want to say that Ontario has been the subject of a major primary care reform initiative. I would call it a joint venture between the Ontario Medical Association and the Provincial Ministry of Health and Long-Term Care. It is quite different than anything that you see in the rest of the country. And Jerry Hurley's group of researchers has been responsible for a major study of the impact of some of the changes involved in this reform. And I think that this is an area that's of great interest to almost anyone that's interested in primary care reform and how you recalibrate our system, both in terms of the payment part of it as well as encouraging certain outcomes through other mechanisms. So what we're going to see is the results of an evaluation of pay for performance incentives to Ontario primary care physicians. Now, Jerry Hurley is in I think, an excellent position both to lead this research initiative as well as explain the results. He's a long-term member of the Centre for Health Economics and Policy Analysis at McMaster University. He arrived in Hamilton in the late 1980s. He actually moved from the United States. He did his PhD at Madison University of Wisconsin in Madison. And he actually grew up in Rochester, New York. So when he arrived in Canada, he actually wasn't even a landed immigrant. And I understand it took a bit of time for that to get all worked out, but once it was worked out, he decided to stay in Canada. At any rate, he has carried out research on physician behavior and physician payment systems for some time now. In addition to that, though, he's worked on various funding models for healthcare, and as every good health economist, he's worked extensively on financial incentives and healthcare systems, but he's also worked on equity as well as the public and private roles in healthcare financing. And some of you may be very interested in the fact that he is also the author of what is now probably the only textbook in health economics in Canada, or designed for a Canadian audience, that we have seen for something in the order of about 20 years. 30 years. And we're delighted that he took the time to do that. As some of you know, writing textbooks is not high on the hierarchy of things that we're encouraged to do as scholars, but it's something that's extremely important, and we're delighted that he did this because we're using it in our own health economics courses, and I'm sure that at the University of Saskatchewan it's being used as well. So would you please join me in welcoming Jerry Hurley.
Thank you, Greg. I'm very pleased to be here speaking to you today. As Greg said, I'm going to be speaking to you about the response of Ontario physicians to a pay-for-performance scheme that was introduced within part of the primary care reform that happened in Ontario. I, as usual, of course, want to first acknowledge a number of people who I worked with. Jinhu Lee was a PhD student who's actually just now recently taken a position in Australia. Phil DeSick is a colleague, and Joria Buckley works in the Center for Health Economics and Policy Analysis, and they all contributed very importantly to this work. So I want to acknowledge that. I also want to acknowledge, before we get into it, a large number of people at the Ontario Ministry of Health who helped with this work. This was jointly done as part of a collaborative research program between the center and the ministry. And we relied very, very heavily on the knowledge and the expertise inside of the ministry. Because to do this kind of work, you really need to understand institutionally, how does the system work? How do they translate an agreement with physicians into the actual mechanisms and policies through which they get paid, including just how do the programs work that run it, and how do things get coded, and how does that come out in terms of the files that we look at. So from some very mundane things to some very high-level important things, we received a lot of help from people within the ministry, so I want to make sure to acknowledge that. Where to start with this? Well, pay for performance has, of course, in Ontario, was introduced in the late 1990s in a very small way. It's something called primary care networks in Ontario. In 2002, it was incorporated into what was then the new family practice model they were introducing as part of their primary care reform. They were called family health networks. You'll be sick of acronyms by the end of this, because Ontario has about 6 different models of primary care, all begin with F. And I get confused myself. But anyways, this was the first version. And this was expanded quite considerably in the 2004 to 2008 agreement. And by this time, there were more types of family practice organizations, and these incentives actually have been continued in the current agreement and modified in certain ways. So they're still in place. We were asked to look at the ones that were introduced in the this agreement 2004-2008, and of course it's taken a little while to get it done. But it was done at the request of the ministry because they wanted to understand. They adopted these incentives. It worked. Is this something that they should be continuing? And of course, pay for performance is a hot button item in health. This is a big topic. It's been sold as something that's going to be quite fundamental to transforming our healthcare systems, improving quality of care. This has been implemented in the UK in a very big way in 2004 in their physician agreement that introduced something like 140 quality indicators and incentives to perform against them. In the US, it's a very big part of many of the private health plans and also their Medicare program. We see it in Australia, something called their practice incentive program. Many, many countries in the world, Germany, so on and so forth. It has become, as I say, a kind of a hot item in policy circles as to trying to address issues of quality reform. In Canada, I think there's little things happening in many places. I'm aware of initiatives, at least in British Columbia, Manitoba, of course, Ontario, and Nova Scotia, trying to integrate it in a bigger way in aspects of their reform. So it's an important policy to try to understand, does it work? Does it really improve quality? Is it a cost-effective way to try and improve quality? So before getting into exactly what we did, I thought I'll give you just a very brief overview of some of the international evidence about the effectiveness of primary care, or pay for performance. It is a relatively limited empirical literature because it's really this took off in the mid to late 90s. Things really started moving in this direction. It's growing quickly because now the valuations are starting to come forward based on some of the early implementation. Much of the evidence is actually methodologically weak because they weren't introduced as part of things to be evaluated. There were policies implemented within certain programs. And the available evidence overall is relatively mixed. And I'll explain a bit more what I mean by that in a minute. A little bit about the UK initiative. So as I said, this was implemented system-wide in 2004, and so one of the problems is, of course, there's no control group. But it's not easy to figure out what was happening because of the reform versus what would have been happening anyways within the system. Secondly, it was only one part of a broad set of initiatives, and so it's very hard to disentangle how much of what's happened is because of the pay for performance and how much is because of other things that were going on and the interaction between them. One of the more recent studies, there have been a couple just come out very, very recently, but Campbell, this paper in 2009, is one that's often cited. And the team essentially did an interrupted time series. They said, let's get a couple of data points before the reform, a couple of points afterwards, and let's just see whether or not we see a change in the patterns of delivery. They focused on 3 conditions: asthma, heart disease, and type 2 diabetes. And they did it in kind of a 2-stage analysis, but the point is simply that they saw some evidence of increased quality for asthma and diabetes by 2005, no change for heart disease, but then subsequently it seemed to have leveled off by 2007. It plateaued and they weren't seeing increases any further. One of the issues here is that in the first assessment, in terms of what proportion of physicians met the targets, something like 85% of them met them. So there's some feeling that A, where the target set at the right level, B, there had been initiatives before this, and so maybe it's simply they had accomplished a certain amount of change beforehand, and they were already, in certain aspects, meeting some of the targets. Just to say, a lot of money was at stake here. This is, you could earn up to about 30 to 40% of your income through bonuses. I mean, this was real money that was going to be affected by their performance. So they had some real incentive to respond. A number of the indicators are process measures, documenting things, and so on and so forth. There's not a lot that's linked to good, hard health outcomes or quality outcomes in a certain sense. And this is going to be true for this literature in general. Mostly it's about measuring process in the hopes that these processes are associated with higher quality. In the US, there have been, again, a couple of studies I would just highlight. Both of these are comparing pay for performance in some private healthcare plans, big healthcare plans on the West Coast in California, in the Northwest of the United States, where you had physician groups, some of whom were exposed to the incentive, and then others in the same kind of broad network which were not exposed to incentives. And so it's comparing over time the performance of the control groups who were not exposed to the incentives and those who were. 2 studies of note on this. Again, they focused on targeted incentives to specific services. The first study, Rosenthal, looked at 3 services: cervical cancer screening, mammography, and hemoglobin testing for diabetes. They found evidence of the response only with respect to one of these, which was the Pap smear coverage, and it was quite a modest response, an increase of about 10% overall, 3.6 percentage points, but about 10% over the baseline level of performance. The second study extended this, expanded the set of services a bit more time. Again, only found an effect for Pap smear and highlighted possibly negative effects for some other areas of usage. So a mixed evaluation in terms of the benefits of this. One of the pieces of evidence that came out of the Rosenthal that was quite important is that, of course, with bonuses, you are given incentive if you reach a threshold, but you're paying that bonus to all the people who are already performing well. And so these can be very expensive policies, kind of per unit of change, because you're giving money to people who are already doing well. And so if you already have a reasonable level of performance, it's really just a true windfall for the people who are already doing well. And it makes it very expensive at the margin, and this is one of the findings out of the Rosenthal study, was that it was really, they judged it not a cost-effective way to try and improve performance. Just the last bit, there have been a number of systematic reviews. In fact, the most recent one just came out about 8 weeks ago, the Scott et al. Report. It comes out of, it was done for the Cochrane Library of Systematic Reviews. The overall conclusion is they have looked across the evidence over time, is again reiterating the evidence is relatively weak, mixed, at best suggesting modest effects for some services and not for others. Again, the outcomes are often processed. We're not really directly measuring quality in many of the cases, and it's expensive per unit change. And this is really the conclusions coming out of these systematic reviews. So as a backdrop, then, this was kind of where knowledge was when we started our particular study. And what was our question? It was really straightforward in many respects. We simply wanted to know, Ontario introduced some performance-based incentive payments for 5 preventive care services. I'll tell you what they are in a minute. And for 6 sets of what I'm just called physician services. They were designated subsets of services. Again, I'll let you see it in a minute. And we wanted to know, did these targeted incentive payments improve the provision of delivery of these services, these specific services to the patient populations who could benefit from them? The particular preventive care services were flu shots for seniors, immunizations for toddlers, cervical cancer screening, breast cancer screening, a mammography, and colorectal cancer screening. So these were the 5 services which is clear evidence of benefit. And a high-quality, well-performing primary care practice should be regularly providing these on a regular basis to the target populations for these services. So we can say confidently, if a practice is really well below, high levels of coverage, there's a problem in terms of the quality of care going on inside that primary care practice. The second set are these identified sets of services for which I would argue that the motivation here was not so much quality as much as there was a feeling that either there was perhaps too low level of services of a certain type, or they wanted to give physicians incentive to stay in the game for that kind of service. So obstetrical services, they wanted to encourage more primary care physicians to stay and to increase the number doing obstetrical deliveries, because that has been decreasing over time. Same thing with hospital. The primary care physicians have been pulling back from the interactions with the hospital setting. They wanted to encourage more of that to happen, and so forth. So these are not so much directly tied to quality as what were perceived to be desired patterns of practice. They wanted to encourage it within the primary care teams. There were some other incentives included within the broad set of the payment, the reforms of the primary care groups, but we were asked to evaluate these specifically. Sorry, this might be hard to read. I want to just give you an example of the incentives. So the first thing is physicians were given, or the practices were given $6.86 for each documented contact for one of these services. So if you contacted a patient or someone in your practice to say, come in to get your mammography screen, and you document, there was a certain requirement to document it, then you would get $7. Whether the patient came or not didn't matter, as long as you had undertaken the effort to bring them in for their service. And you could get this for each of those services. So you could contact someone for 5 different services and get 5 times the $6.86. Then the next list is an example of the actual preventive care bonuses. And what you see is a threshold system of different levels. So this is the seniors flu shot. Target population is obviously patients over 65 years of age. And if you deliver a flu shot, or I should say, if at least 60% of your patient population over age 65 gets a flu shot, you get a bonus of $220 on up. Then if you're able to reach 80%, then your practice received $2,200. So it's a graduated threshold system. Pap smear, you can see the target population, obviously it's females aged 35 to 69. And there it was if that patient had received the service within the previous 30 months, then you got the bonus payment. The special payments for these other services operated a bit differently. It was really a threshold. They specified a level of provision, in this case obstetrical services, 5 or more deliveries, then you got the payment of $3,200. If you didn't get the payment. It's just a kind of binary threshold system. One thing I would say also is, for the preventive care payments, you didn't have to deliver the service, in the sense that it was just if the patient had gotten it. So if someone had moved into your practice on February 1st, and this reconciliation is done on March 31st, you got the credit for it if the patient's previous physician had done it. So it didn't matter if you did it, it was just if the patient had gotten it, the service in the time period under consideration. And we're also going to see there's some difference. In most cases, the payment went to the practice, not to the individual physician. And if they're multi-group specialty or practices, then of course there's an issue of, well, how did the practices decide to allocate that revenue amongst the providers? We don't have good information on that. Later, partway through our series, if a group unanimously voted, the payments could go directly to each physician in the practice. So there was some flexibility about how it was handled partway through the process. How did we evaluate this? We used what we would call a difference in difference design. We have a control group. That's going to be the fee-for-service physicians who never were eligible for these bonus payments. Then the physicians who were eligible to receive these payments. We're going to follow them both through time. So before the policy was implemented, both the fee-for-service physicians and those in the primary care groups were not eligible. Then the policy came into place. The primary care reform group practices became eligible. So what we can do is we can compare them. How did performance change in the group that was eligible for the incentives compared to the fee-for-service physicians who were never eligible for the incentive? So that's what we're going to be using as the basic way to try and identify what was the impact of these incentives. Our unit of analysis is an individual physician because that was the basis for determining whether the incentive payment was made or not, was each individual physician's practice and the proportion of patients who would receive the services or the number of services the physician themselves had provided. So that's a logical unit in which to carry out the analysis. It meant, well, I'll get in a minute, so it meant defining each physician's practice, including fee-for-service physicians for which they're not rostered, right? Because in the primary care groups, they have rostered patients. People have to enroll for that physician for the most part, and we have a defined roster. For fee-for-service, of course, there isn't that, and so we had a mechanism, an algorithm for defining what was the practice population for that physician. We used a number of sources of data from the Ontario Ministry of Health. Their claims data, which tells us, of course, for every individual in the province, what specific services did they receive each month, how many times did they receive that. The registered persons database gave us information about each eligible beneficiary within the OHIP system. The corporate provider database told us about the physicians themselves and some of their characteristics in their practices. The client agency program enrollment, that's just the roster database it gave us for each physician who was in a primary care reform practice, what patients were rostered with that practice. And then the breast cancer data, it's a wrinkle. In Ontario, if you're an eligible woman, you can get your mammographies done through your primary care physician, or they have specialized breast cancer screening clinics. And they're completely distinct ways in which you can go get your screening done. The problem is this, of course, these data from the specialized clinics are not integrated into the physician billings data. And so if we were able, however, to capture those data and then integrate them into our database so that we actually can capture all of the breast screening that happened. It doesn't matter where it occurred in the province. So what we're going to have to, in terms of the analysis, we're assuming the fee-for-service group are a relevant control that can tell us in some sense what would have happened had the policy not been in place. Okay? That's going to be a baseline assumption we're going to have to make in inferring what was the effect of the program by saying let's compare those who were exposed in the primary care groups against the regular fee-for-service physicians. We're essentially assuming that the people in the primary care groups would have behaved like the fee-for-service physicians had they not been participating in the program. We are able to control for certain kinds of characteristics of the physicians in their practices. I'll tell you in a minute, there was differential eligibility. As I said, there's a number of these different primary care groups, and they weren't all equally eligible at different times. And so that's going to help us because one of the things you have to worry about is, well, if you had to be in the primary care groups in order to be eligible for the incentive payments, and to be in a primary care group, you have to commit to, for instance, evening coverage. You have to commit to certain kinds of multidisciplinarity. You have to commit to a whole set of things that associated with being in that group practice. And our concern is, how can we distinguish the effect of the incentive payments from these other characteristics that might have changed at the same time that the person joined the group? And what we're able to do is, for some physicians, they join the groups before the incentives were ever created. And so we have physicians, we now can separate the effect of joining the group from the effect of creating the incentives. And that's going to allow us to distinguish the incentives from these other characteristics, other primary care groups. And we're going to do some subgroup analysis along who, of all the physicians, do we see differential response based on certain characteristics. Their baseline level of provision, their age, and their practice size are what we're going to be focusing on. So this is the basic features of the design that we're going to be using to try to identify what was the impact of the pay for performance incentives. Here is the sample that we're going to use. So we started out with, we have data over a 10-year period from 1998 to 2008. Monthly data on every service received by everyone in the province of Ontario through that whole period. Over that period, there were 37,000 plus physicians who at some point were providing services within the Ontario healthcare system. We, of course, so then we first got rid of those who were not present during the 10 years of the study period. It just made certain parts of the analysis simpler. That dropped about over 21,000 physicians. We then said, we don't want to, obviously we don't want any specialists, so let's get rid of anyone who's not a primary care physician, a GP or a family practitioner. That got rid of about another 8,000. We then wanted to focus on those who were practicing at or near full time. We didn't want people for whom, you know, they were only practicing 1 day a week or something, because you wouldn't expect them to respond as much, and they're not the real target anyways. Their practice is very atypical. So we wanted to focus on the typical, relatively full-time practitioner, so that eliminated some. We then said that we don't want physicians who are just ramping up practice, because their trends are going to be very unusual, because it's going to include this period when they were ramping up. So we eliminated those. You had to be in practice at least 2 years before the start of the study period. As you know, a number of primary care physicians now, or GPs, they specialize. They specialize in sports medicine or psychotherapy or some area. So all that, it's still an Ontario jargon about codes AO1, AO3. That's just saying we're eliminating people whose practice really was specialized, even though they're GPs. Again, we're interested in the typical family physician providing a broad range of services to their population. And then we got rid of a few small groups, locums, people who were not exposed to the incentives, and so forth. So we ended up with a little over 2,000 physicians, 2,185 physicians in the group. In terms of, actually, I think I'll show you this is better slow now. So you'll see the beginning of the study period, the 2,185 are all in fee-for-service, because that's all that existed. Then, starting in 2002, they created the first set of these FINs, these family health networks. And you see by the end of the year, there's 13 physicians who are in that group. That same year, in the next year, we saw these family health groups established. And so they first enter in 2004. And then 2 years later, these comprehensive care, what's M? I can't remember what M stands. Comprehensive care, I'm forgetting now what the M is. Anyways, it's a different type of group created. And then finally, in the last 2007, Family Health Organization is the last one that's been created. So these are the different types of primary care groups, and you can see the physicians then spreading out over time during our sample period. The FIN is funded primarily through blended capitation. The base is capitation, then they get 10% of the fee for every service they deliver to the patient. So the primary basis is capitation plus this blend of fee-for-service. The FIG is essentially fee-for-service with a bit of blend from capitation. Both of those, it has to be a group of at least 3 physicians and a set of other criteria. The CCM is again fee-for-service with a bit of blend of capitation. You can be a solo practitioner. That's the difference between CCM and the FIG, essentially, is you can just be solo. FO is back to a blended capitation basis. FO has now grown so that currently, I think this year, over 40% of Ontario family physicians are in FO. That's blossomed. They've given them, basically, large incentive to join in the form of very high rates of payment. So you see the physicians distribute themselves during their study period over these different practice models. And just to go back then, so in terms of what we studied, in order to understand the preventive care bonuses, we simply looked at March 31st of each year, because that's how it was implemented. They looked at the physician's practice on March 31st, looked at the 30 months before, or the 24 months, whatever was relevant, and said, what proportion of this physician's practice got this targeted service? So that's what we did, is we just calculated what proportion of people in this physician's practice got the targeted service. For the special payments, it was just a dichotomous yes, no. Did the physician provide above the threshold or below the threshold in terms of receiving the payment? So that's how we defined the outcome that we're trying to understand. In the independent variables, again, we've got a set of physician characteristics, practice characteristics, and then a series of variables to try and control for the year, for the geographic location of the practice, and then whether or not they were in the group that got exposed to incentives or not, and so forth. It allows us to identify the impact of the incentives. So those are the basic underlying things you're able to measure as part of the evaluation. This gives you a picture of what I meant by the differential timing. So when this tells you in 2002, for the flu immunizations, toddler immunization, pap smear, and mammogram, these fins were the first group exposed, and notice that is when they were created. So for that group, there is a coincidence in time between joining the group and being exposed to incentives. But for the FIGs, the CCM, and the FOs, they were all established prior to when they were eligible for receiving the incentives. And we also have different years for some of the different incentives. Colorectal cancer screening was 2006 or 2007 that came in. So a lot of variation within this basic system of incentives that allows us to distinguish the impact of the incentive compared to other things that might have been going on in the healthcare system at the time. So we're going to exploit this to try and figure out the impact of the incentives. Here's some descriptive statistics. I'm sorry how well you can read that. I'll give you the bottom line, which is, it won't surprise you, those who joined the groups and got exposed to incentives are different than the physicians who stayed in fee-for-service. They tend to be younger. The ones who joined tend to be a little bit younger, a higher proportion of females. They tend to have slightly larger practices. They tend to have slightly younger practices in terms of the age of the patient population they serve. They work more hours, work more days. They have a higher number of visits, and they have a little bit higher visits per workday. So they do differ systematically on a number of dimensions that we could measure. This is not a problem for us, per se. The fact that they differ at the baseline, this is all measured in 2003. The fact they differ at the baseline is not a problem. What we have to worry about is whether or not the trends in their practices differ. That's what we have to worry about. We are able to test for that explicitly in certain ways. I can tell you that in general, the evidence suggested that the assumption of what's called parallel trends, that they're moving together, we could not reject that. In other words, the statistical evidence suggests that the trends are similar, and therefore we do have a legitimate basis for doing this comparison. Even though we do know that the composition of the sample differs at baseline. So let's get into the results now in terms of what we found. So this is that payment for simply contacting your patients and in order to get them to come in, or at least encourage them to come in. The bottom line is there's been no response whatsoever to this payment incentive. This table tells you the proportion of eligible family physicians who submitted even one claim, or even one individual who they contacted to encourage to come in for the service. And I will say we have some small numbers issues here, so there's a lot of variability in the data. But there's clearly no trend across any of these, except the downward trend for toddler immunization. But we see for pap smear, the first year they were eligible, 43% of them did, then it dropped to 28, up to 44, down to 37, down to 30. There's no systematic relationship going on here. in terms of this payment. So this suggests that, in fact, this payment had no effect. To be fair, it also suggests they didn't pay very much because not very many people claimed it. But it didn't have much effect in terms of encouraging them to contact patients. This is now looking at the preventive care bonuses and what effect did the bonuses for them have. So this table, the left-hand column, most column, tells you what incentive we're looking at. So there's the 5 incentives. The second column tells you what was the baseline level of provision. So for the senior flu shot, 55.4% of seniors received the flu shot in the baseline year before the incentives were in place. Toddler immunization 54, Pap smear 58.9, etc. So that tells you the baseline. The third column tells you what was the increment induced by the incentive program. So for the senior flu shot, it tells us that the percentage increase over 55.4 was 2.8 percentage points. So essentially the incentive had to go from 55.4 to, what is that, 57.2 is the proportion of people who received the flu shot. And similar interpretation for Pap smear, it increased by 4.1 percentage points on a baseline of effectively 59%. Mammogram increase of 1.8 percentage points on a baseline of 65%, and colorectal cancer screening an increase of about 8 points on a baseline of 15. So a couple of things stand out here. First of all, the very low rates of coverage for some of these services, which is a bit disturbing. Secondly, the 4 of the results are statistically significant, all in the expected direction. 3 of them, I think, would certainly be seen as quite modest changes. You're not buying very much change with this incentive program. The colorectal cancer screening is the one that is largest both in absolute terms, but also, of course, in proportional terms because the baseline is so low. I'll simply say I'm a little worried about that number because in Ontario, there was a universal screening campaign started in the latter years, just around the time this was introduced. Now that should have affected, or that targeted both all Ontario population, including those in fee-for-service docs and those in PCRs. So you would expect it to affect both. But the question would be whether there's any interaction, whether or not there's any reason why physicians in the primary care groups would have responded more to that universal campaign than those in fee-for-service. I can't say, but I'll just say that I think some of that may be some confounding, some introduced by the introduction of the universal colorectal cancer screening program in the province, with a lot of publicity beyond the incentives. At any rate, the message here, as expected, but quite modest increases in terms of effectiveness. When I've just added, this is the same table with a new column added, and now we restrict it only to those physicians who were in a PCR model before the incentive programs were introduced. So now we're completely distinguishing any effect of joining the incentive or the practice from any effect of the incentive. What you can see is that the estimates are almost identical. It changes very little, so that we're not worried about confounding between the practices themselves and the incentive program. No conclusions would change even in a quantitative sense when we focus on just a subset for which the decision to join the group was completely distinct from the decision or the being eligible for the incentive. We then also said the group that's going to be most like the fee-for-service comparison are those in primary care groups who are paid by fee-for-service. So let's compare those two since they're the most similar. And again, the result is no change in conclusions, very, very similar estimates in terms of the effectiveness of the program. So again, it suggests that even when we focus on two groups are really very much more likely to be quite similar, we get still the same estimate of very little impact of the program. This is now the special payments. Remember those groups of obstetrical services, hospital services, and so forth. This table is a bit more complicated because of the nature of the incentives and so forth. What I really want you to focus on is simply in each column of the marginal effect, what you observe is there's almost nothing that is statistically significant here. There appears to be almost no response. There is some suggestion around prenatal care, and some suggestion in some cases around office procedures. But the overall picture is of no response, really. I'll say that we have a smaller number of physicians who are exposed to these incentives, so we don't have as much power for this particular analysis. But even ignoring that, you can see the estimates are very, very small. Even if they were to become significant, the policy significance, they wouldn't be there because it's just too small a response. When we did the subgroup analysis I spoke about, we did it by physician age. What we found was that basically younger physicians responded more than older physicians. It wasn't a huge difference, but there was a clear difference between them. In terms of the size of the practice population, a relatively weak gradient, but it appeared that those with larger practices were slightly more likely to responded slightly more than those with smaller practices. It makes some sense to the extent that they may be able to organize their practices more easily to deliver these services. They're more likely to have nurse practitioners and other kinds of providers who are perfectly capable of providing these services in a high-quality manner. So not entirely surprising. Baseline level of provision, also not surprising. The ones who responded the most are in the lower middle quartiles, and particularly the middle. And those are the ones, of course, who are probably more closer to the borderline. So with a little bit of effort, they can get some of that bonus. If you're very low, you got to really work to reach the threshold to get the payment. If you're very high, then you're already there. You don't have to do anything different, and you're still going to get the payment. So as you would expect, the biggest changes happened around the middle of the distribution of the baseline level of provision. We did a bunch of sensitivity analysis. Again, details don't matter, but those in the primary care practice had a little bit different option in terms of how they could bill things that might have given a reason to believe that they might have simply documented some of this better than the fee-for-service physicians. So we did some sensitivity analysis to verify that that was not driving our results at all or affecting our results at all. Again, some various aspects of how we define the practice population. We had a broad definition and a more narrow definition. Didn't change our results at all. And this issue about small, there was a rule about you had to have a practice of a certain size to be eligible, etc. So the point is, all these sensitivity analysis, nothing changed our conclusions about the effectiveness and incentives to modify the analysis in these ways. So what do we conclude? That there's no evidence of any response to the special payments, that there's evidence of modest response in 4 of the 5 preventive care bonuses. As I say, I would emphasize modest, no response to the toddler immunization incentive. The pattern of responses, I think, makes sense in that it's particularly between the preventive care versus the special care bonuses. The preventive care, most of that is the cost of increasing immunization rates or screening rates is not high. It's something that can be done relatively straightforwardly in the context of a primary care practice. There is clear evidence, any primary care physician should know these are effective services that they should be delivering to their patients, and so there isn't any question that this should be done. There are also probably the kinds of infrastructure required to invest in them are quite similar. It's a screening within your practices, and so there's complementarity and benefits across the specific services. So all those suggest that these are like reasons why you might expect response amongst them, but not the special payments. Special payments, I mean, if you're a physician who's gotten out of deliveries, to get back into the deliveries game, and that's huge implications for your practice. Even to simply start hospital visits, that means you got to reorganize your day of your practice to be able to stop by the hospital. So large costs for services where it's not like it's linked to strong evidence that this is going to improve quality. So it's not surprising that no response amongst those services. Certainly our overall conclusion is that this is another study that suggests really pay for performance incentives don't look like a particularly effective way to try and improve quality or even patterns of service delivery of certain types. Thank you.
Thank you, Jeremy. That's quite a result given the amount the Ontario government has invested in this. So Perhaps we can begin in Saskatoon and then we'll move to Regina.
Okay, great. Thanks very much. Questions for Dr. Hurley? Points? Do you want to come up and use the mic? We have one question.
Thank
Hi,
you.
Dr. Hurley. This is Regina from Saskatoon campus. My question is pay for performance. From the word, it seems like performance should be measured by the outcome. Although this is a preventive service, but it's still not health outcome. It's not health status. Is there any, and the UK tries to measure quality of service and the time of direct care to patients, for example, such measurement. Is there any such measurement in this study or in Canada?
There's no health outcome measurement in this study for sure. The vast majority of studies of pay for performance do not include actual health outcomes. They are, as I say, process measures of care. Some of them don't even get at actual utilization measures. It's simply reporting. It's just recording of certain events and so on and so forth. So your question is a very good one. I'm aware of really almost no studies that extend the evaluation all the way to documenting actual health effects in the populations that are being served. The best we get are these certain services that are highly well documented to have health benefits in these targeted populations. And therefore, there's reason to believe that improvements in process in these specific dimensions will lead to improved outcomes. But you're right, there's very little to no evidence on that directly.
Just quickly comment on why it's been why so few studies have built in health outcomes into the research design?
Because most of these are not done prospectively. It's done after the fact, and you have to go back and you try and measure whatever has been data routinely collected through the various data systems. And health outcomes is not one of those pieces of information that is routinely collected. So I think that's probably the biggest reason is they did not implement an evaluation design at the same time they implemented the policies themselves, and so you're always stuck doing these retrospective designs. That's for the bigger issues. There are some of the studies include randomized controlled trials that were obviously prospectively designed. They tend to be very small, very targeted populations, and frankly, even they often rely on process measures. Some of it's because some of these outcomes also would be a big lag. We'd be waiting years for some of these outcomes to find out what the impact was on an increase in mammography screening, and then you're going to have to look many years in the future to the impact it's had on breast cancer and so forth. So there are some very pragmatic reasons why we can't do that for some of these services as well.
We have one more question here.
We could
Oh, wait.
I have a question. The difference in difference, the result depends on, it's a general equilibrium effect. So the take up of more services depend on both the supply side and the demand side. So I'm just wondering, could the modest effects and some of the non-effects partly is because elastic demand. I don't know, but I'm just curious.
It's possible for sure. I guess what I would say is I think for many of these services, patients do seek advice from their providers, and so I do think physicians have some ability to influence the rates of uptake simply through reminder systems and so forth. Right? I mean, there is evidence that certain kinds of reminder systems and other things can increase rates of the uptake of these services. So it does suggest that certain interventions can be effective. But you're absolutely right. I mean, there is an extent to which physicians may exert some effort if patients don't respond by coming in for those services. Then it's conceivable they just said this isn't worth the effort. And in fact, some of the cause, therefore, is in the demand side. I guess what I would argue is in terms of this particular policy, it still tells us that pay for performance isn't going to fix the problem, but it does suggest when we think about other alternative policies that perhaps we have to do something more on the demand side if, in fact, as you say, part of the reason for the lack of response lies with the patients themselves.
We have another question in Regina, but I want to know if there's any questions in Saskatoon.
Yes, we have another question here. Let's go ahead.
Thank you, Dr. Hurley, for your presentation. Really interesting results that you have presented. And well, I have two questions. The first one is, have you measured or think about other variables that can provide some evidence of negative impacts of pay for performance incentives? And the second one, how do you suggest to measure and compare the impact of this kind of monetary incentives against non-monetary incentives? Thank you.
Okay. So the first question about unintended consequences, I think as people think about those unintended consequences, we think primarily about diverting attention from some other valuable services in order to provide the services that are the target payment would be one of the most important types of unintended consequences. So you could try to look to see if there were patterns of ways in which if physicians had diverted energy away from others into these target services, I'm going to guess that given the low rates of response, in this particular case, we wouldn't see much. If we had large responses, then I might be worried to say, geez, maybe we need to look and make sure that it wasn't a matter of them simply refocusing and they gave up doing some other things that were quite valuable. And that, of course, is always a huge concern in the incentives literature. There are some documented cases of unintended negative consequences of these pay-for-performance schemes that are in the literature. Again, we did not look for them in this case, and I wouldn't really expect to find them given the minimal response we have in the first place. Your second question, and I've of course forgotten it in the process of answering the first one, it had to do with different measures of comparing non-monetary and monetary. Thank you. Well, so first of all, one could in principle use the same kinds of designs in terms of research designs to try and answer the questions. It's simply the intervention that differs. And so in principle, there's no issue there. I think my sense out of the incentives literature is that the effective policies will be ones that actually try to work on both aspects of the payment process, but also the non-monetary aspects of practice, both rewards and penalties and so on and so forth. But even beyond that language, which is just reward and penalty, but just changing the culture of practice and changing how physicians think about what they should be doing. I think these can work together. In fact, I think the best situation is when they are working together. I personally, I'm trying to say this carefully because I know sometimes it gets misinterpreted. I'm an economist, so of course I think about incentives. Incentives are terribly important. You always have to pay attention to financial incentives. There's a difference, though, between trying to create a payment system that doesn't penalize providers for doing good things that you want them to do. In other words, the incentives aren't being a barrier to what you want. That's a different thing than saying we want to actively use incentives as a tool to tell physicians or providers what we want them to do. Right? Those are very different ways of thinking about incentives. We have to do the first. We have to think about how fee-for-service or capitation or a particular blend or salary affects their incentives to undertake the kinds of activities that we want. And so, yes, I personally think the overall incentives literature says that we aren't very good at designing policies that use targeted financial incentives. And the evidence is that the responses to them are very mixed. Sometimes they do, sometimes they don't. We really don't understand well why they do in some cases and not others. So I would say let's pay attention to the incentives in forms of the funding models we use and the payment models at some macro, some big level to get the incentives right. But then let's use non-financial incentives to try and support the change we want, support the kind of practices we want, make it easier for them to make the changes for both financial and non-financial reasons. And I think when they're working together, that's when we start to see change happen that's more permanent and effective. So I tend not to think of it as either or, but it's seeing them as two aspects of your policy that have to work together.
Yes. My understanding that patient gets listing of services that they provide, and they give us an amount for each service. So how is that fee for service different than that for the department wishing to perform what other services than their current? What's the critical difference between the two? Why not just increase the fee for service for that function?
So the basic funding models in Ontario are the traditional fee-for-service, which as you described, there's the fee schedule with 5,757 items, and each time they do one of those, they submit the claim and they get paid the fee listed in the fee schedule. The blended model for some of the primary care groups is an age, sex-adjusted capitation payment for each person in your practice. And then for each service that you deliver, the same fee schedule applies. It's like now you only get 10% of the fee listed. So the advantage of that are a couple of them. One of the concerns with pure capitation, of course, is if at the margin you get absolutely nothing, then it encourages underutilization, underprovision. Whereas this at least gives a little bit at the margin so that they get paid a little bit for delivering the service, but it's not so much that they're gonna run to the bank with it all. I have to say, from an administrative point of view, it's great because then you still know what's being delivered because it's still recorded in the system and you can see what's going on. If under pure capitation, you have no idea. They have shadow billing systems, but we know those are not high quality, valid systems because there's no incentive to record things properly. Nothing hinges on it. But these blended systems are trying to kind of eliminate the negative incentives associated with both fee-for-service and capitation and to give a balance of incentives across the two kinds of payment systems. In terms of your question, why don't they just, within the fee-for-service system, why don't they just have targeted payments? It's perfectly possible to do. And it has been done in the past at times when, not under the banner of pay for performance, but just they wanted to encourage certain provision, and so the fee would go up for a particular service. The studies of responses to fee-for-service, relative fees in fee-for-service, again, are they're not clean. We actually did some work on this 20 years ago. One of the very first projects I did when I came to Canada was looking at do physicians respond to changes and differences in relative fees within the fee schedule. And it was all over the place. And part of it also is to think about when we increase the fees, let's say for one service or for a set of services, we tend to think, the only response would be to increase services. But within even just a standard economic model, if we think leisure is something that people like more of as they get wealthier, higher incomes, then when you change the fee, you get two effects. One is you've made it easier, in a sense you've made them richer because now the fee's higher, and if they change nothing at all, they're going to have higher incomes. That might say, well, I'm going to work a little bit less. And so you could have something whereby you actually induce them to work a little bit less. They may allocate a bit more of their time towards the things you've just targeted, but you may not see an increase in provision overall because you've affected both the total amount of work effort and the allocation of the time across services. Absolutely. Yep. Yeah. And we know that in certain, the evidence is sparse, but there are certainly studies which show that physicians are on the backward bending part of the supply curve, labor supply curve, so that in fact, we know many physicians want to reduce work hours, that a policy of increasing large fee increases in general may actually elicit fewer services at the end of the day. It's, to go get a particular service. Two parts to that. One is, I do think, if I were a policymaker in Ontario, actually, I asked for them for the number, but they have not gotten back to me about exactly how much money do they spend on these incentive payments. I don't know how many millions they spend. But on the basis of this, I would suggest actually you should take those monies and you should divert them to another program that you think is effective, which is evidence that it's going to be effective, and I realize that can be hard at times to find, well, what do we know is effective? So as a generic principle, that's something that I would see doing in this particular case. As to incentives to patients themselves, I don't know of any evidence about how effective it is to offer them payment to go get particular services. I'm not sure.
We have another question here. I just want to quickly check. Are there any questions from 2 Research Drive? If not, I'll proceed here. Oh, yes, there is.
We have at least one question here.
Hi. I know you mentioned that larger practices generally respond more to the incentives. Did you take, in your study, did you take any look into how the administrative cost affects physicians? I know that smaller firms would probably have less people able to do filing of the claims, and so they would be less likely to actually file for these incentives. Was anything done to look at administrative costs versus incentives received?
We had no information on the administrative costs associated with responding to these incentives. So the short answer is no. As part of preparing or part of doing this study, before we got an actual data analysis, we consulted with the leader of one of the large practices in the Hamilton area. And he actually had hypothesized that it would be the smaller practices that would respond more. And his argument was that if you're a smaller practice, it takes fewer patients and it's just a bit easier to kind of hit the threshold because the thresholds are defined in proportional terms. So that was his hypothesis. I think the fact that a bigger practice is just more likely to have the kinds of infrastructure that can help you. You're going to have more office staff. You're going to have more things computerized. I think it's just more likely you're going to be able to keep track of how you're doing. Although actually the ministry did send updates periodically as to where they were. But I just think certain kinds of infrastructure are more likely to be in a large practice. That said, I don't want to overplay this. There was a difference. It wasn't a huge difference between the large and the medium and small practices. It was a gradient, but it wasn't a terribly steep one in terms of the differential responses.
Any other questions from you? Okay, we're good on Research Drive. Thank you.
No, there were no pure capitation, except it's possible. Let me go back to show you this slide with a different. Actually, no. The answer is no. None of them were pure capitation. Partly because we have actually worked in the past with some of those shadow billings data, and we just know that they're not high quality. And that's why we excluded that one group on the exclusion criteria, the SEMO, all this. That's because those are pure capitation, and the shadow billings we don't trust.
I have another question here, but I want to go back to Saskatoon first.
Yes, there's one more question here.
Thanks, Lisa.
Hi, Dr. Hurley. I want to ask quite a provocative question. So you mentioned this people's performance initiative is to try to encourage some targeted targeted preventive service. But on the supply side of healthcare, doctors are high income, and the evidence showed the response rate is not very high. Do you think about the demand side from policy making perspective? The people who don't want to take up some screening test or other preventive service are usually low income, low education. If we spend those money on the patients, wouldn't the outcome be better than spend on doctors?
Again, a good question about the role of the demand side in explaining these results. It would be interesting. We don't know the patient's socioeconomic status other than we do know the location, so we could conceivably assign them in terms of the census tract or the census enumeration area in which they live. We have not done anything like that to look at differential response amongst the patient populations of different socioeconomic categories. I think again we're back to that may be promising, that might be quite an interesting thing to explore. I'm not aware of any pay-for-performance systems that take that into account, and so what you're suggesting really is, again, an alternative to this, which targets various aspects of the demand side. And as you say, particularly these are the patient populations for which compliance is probably the lowest for most services of this type. So that is perhaps a promising alternative way to think about the problem of wanting to improve quality. I have to confess, again, I'm not familiar with any evidence about any specific programs that try and target. I think in that case you would often be, again, you would not be using as incentives, you might be investments in ensuring access to services in those areas, because oftentimes there is a bit of a supply side problem and that their clinics aren't as readily accessible at times to those populations. But I think fair enough what you're saying is there's also often less appreciation of the benefits of the services. It's clear, we have a number of studies which show there's a clear gradient related to education in terms of your knowledge of your risks, your not just your ability to process the information, but your interest in information, scientific information and so forth. And so it is partly a supply side getting the services into the areas of high density of low socioeconomic and so forth. But as you say, something to try and overcome what has some real barriers in the quote-unquote the demand side in terms of the recipients of these services. So maybe a promising way to think about this. I'm sorry, just in general, we know with new technologies that, it's often a disturbing side effect, but because higher educated, higher income people they're more aware of things, they process information, they tend to be more compliant, and they probably are more effective in pressing their needs and demands within the system. And the introduction of new technologies often increases the socioeconomic gradient in the use of these services. And so within a universal system that makes everything available free at point of service, simply introducing the service is not enough, and it often exacerbates the current existing inequalities in access and utilization of services. Certainly we found that very clearly in Ontario. We personally, some other researchers in Ontario found that very, very clearly with the expansion of access to MRI and some of the other diagnostic services. The income gradient just grew quite dramatically.
What I find interesting about this is it seems to reflect, these programs seem to reflect the type of things that physicians are asking for in terms of pay performance. They seem to prefer these process measures. You may have kind of already answered it, but I just thought I'd ask it in a slightly different way. Are you aware of any programs that are doing things like patient pay per performance, which is a new type of initiative, or promoting provider-patient relationships, or having some type of system navigation incentivized within their program?
Again, the short answer is no, with the caveat that that has not been a focus of my research and so forth. So the fact that I'm not aware of it doesn't mean that it isn't happening. There may be initiatives. I mean, the suggestion, I have to say this is very interesting because I've given this talk a few times and I've never had people identify the demand side as a real source of possible explanation for this and the place we should be thinking about interventions. But your comments and a set of them makes me think of and I'm forgetting the name of the programs now, but they were pioneered in some countries like Mexico and some Central American, where you pay students to go to school, for instance. And they have been found to be actually quite highly effective in increasing school participation rates and so forth. And they've been widely studied and widely evaluated, and they're now actually migrating into some higher income countries as these demand side policies, which is shown to be effective in these contexts. And part of it is even thinking about what role education is playing. I mean, sometimes it's just having the person sitting in the seat in the school. It's keeping them out of harm's way, even if they're not learning anything. It's just keeping them out of harm's way until they grow up a little bit. But at any rate, I had not thought about this, but that was the closest analogy I could think of to demand-side programs to try and induce people to uptake what we think is beneficial to them. In this case, I'm aware of education programs, but I'm not aware of it in terms of healthcare programs. Interesting idea.
Perhaps that's one of the difficulties when you have a system already structured under first dollar coverage. To experiment with that assumes you don't have first dollar coverage in a way to provide the incentives for people to take advantage of that. Other questions, Saskatoon? Lisa?
No, we're done. Thanks.
Okay. No further questions. Oh, there's one last question. We'll call it.
There's one over here as well.
Oh, maybe we'll gather both of them up at the same time. Then. Thank you.
I just wonder what the political response to your conclusion.
We'll gather up the second question. Remember, I'll grab you a piece of paper.
Okay.
There's lots of data that you collected, statistical analysis that you did, outcomes. I was wondering if there's room for more quantitative analysis with respect to, for example, you reached the decision, this is not good, or why, that type of analysis led to something.
Okay, so two questions. The first one is I'm not well enough connected politically to know what the political response was. So I don't know. Short answer. In terms of your question, I've heard absolutely, we submitted the report and I heard absolutely nothing from them, other than that I did give a presentation in which there was a great deal of interest amongst these civil servants within the ministry, and well attended, and lots of questions. But I don't think that was very high up in the hierarchy of the ministry. Your question, should we do more better ROI type of analysis and so forth? I mean, yes, in some sense. I guess what I would suggest though is if you have very modest effects and you're spending very much money at all, it's very unlikely that you're going to get a very attractive rate of return for your investment. I think the other side of your question would be if we acted, we said, really, this didn't look like a very effective program, let's take the money out. I think the question really then is, where do we think there's a better investment? And do you have an identified program that you think will do better than this particular investment has done? And I have to say, again, the broad area of quality, I come at this more from the incentive side, not from someone who's extensively researched quality initiatives, and therefore this is being one of them. I don't know what other kinds of interventions on the quality side are out there and that have been shown to be really clearly effective, that are relatively straightforward to implement. There is an initiative going on. It's now linked with the Health Quality Ontario Council that uses a much more provider-focused, not financial incentives at all, culture change kind of idea in terms of practices that's going on right now. It's being led partly by Dr. Brian Hutchison, who is a primary care physician who used to be director of CHEPA, actually. He's retired now, but they've done a fair bit of work the last few years. I don't know how much rolled out that is. The other part of your question, you asked about the scope for other complementary methods. I think absolutely. I mean, if we'd had the resources and the time, it would have been very nice to go off and do a set of interviews with the physicians themselves and ask them, so what does this mean to you? When you found out about it, what was your response? Why did you not respond? We did a big incentives project many years ago, almost, well, 15 years ago anyways, in general within the healthcare system, and that used both qualitative and quantitative analysis, and we certainly learned a lot out of the qualitative component of that study. So I think very often it's very useful, particularly for making sense of these kinds of results and numbers, because it can obviously give you information. The numbers just, no matter how much we try and squeeze these numbers, we're not going to get verbal explanations about why they did or didn't respond to them. So important kind of work. Yeah.
Jerry, I want to thank you. I think this has really given us an insight in how you do very high quality health services research, and I want to thank Jerry for sharing this very important piece of work. There are a number of people in here who grapple with this issue from the perspective of the Ministry of Health all the time, and I think that they're very desperate to learn from other experiences, and I think the Ontario experience is probably the largest single experiment in the country with changes in these kind of not only the payment systems in terms of the different practices, but also adding the layering on top of that to pay for performance. So we very much appreciate you sharing this with us, and on behalf of everyone, I would like to thank you. Lisa, thank you very much for getting everybody to get up to the microphone. That was very helpful.
No problem. Good. All right. Thanks. Bye.
Bye. Okay.